And hello, everyone. And let's just get started on time so that people can get back to work here in the US on time. And I'm referring primarily to Dr. Henok and Dr. Tesfaye. So as usual, this is a wrap-up session for the series we had conducted on cardiology and vascular, if you will. And what I would like to do is ask both Dr. Henok and also Dr. Mikias to kind of maybe mention the highlights of what they have said and talked about during their presentations, just to summarize some critical elements, and then we'll just open up for some clarifying questions to the audience. And if we have some extra time, as I mentioned earlier, from my presentation from last Wednesday, I have a part 2, which is on critical limb ischemia that I can finish by today, if that's possible. If it is not, I can do it any other time. But without any further delay, let me ask Dr. Henok maybe to make his remarks, and then I'll go to Dr. Mikias. I hope, Dr. Mikias, you're not rushed in terms of time.
No, I'm not actually. I have all the
okay,
time.
Perfect. Perfect. So, Henok, would you just summarize, maybe highlights, and then we'll move on to questions.
Okay, well, good afternoon and good morning to the folks in the US. Last time we spent quite a time on the cases, so probably you're going to get the full slide on atrial fibrillation and atrial flutter. But to summarize, atrial fibrillation is a supraventricular arrhythmia that originates from the atrium. The mechanism is reentrant micro reentry. And when we talk about arrhythmia, we have to know the rate at the atrium and ventricle. In terms of atrial fibrillation, the F waves, the atrial rate is around 400, and the ventricular rate is 100 to 160. How we diagnose is by EKG. What you see is irregular R to R wave with absent P wave or fibrillating waves. And the atrial fibrillation is, we call it disease of old age. Incidence and prevalence increase with age, and by the age 80, above 10% of the population have atrial fibrillation. And there are some risk factors for the development of atrial fibrillation. Hypertension is the commonest here in the West, but there are a lot of different causes that can precipitate atrial fibrillation. Rheumatic valvular disease, mitral stenosis, MR, and some pulmonary diseases like pulmonary embolus, any pulmonary disease like COPD, pneumonia, and ischemic heart disease, and also thyroid diseases. By the way, patients in the old age, when they present with atrial fibrillation, we check them for any hyperthyroidism, because it can cause atrial fibrillation. So one of the workups is to do TSH on those patients. And as of late, sleep apnea is considered as one of the risk factors for atrial fibrillation. We see patients with sleep apnea increase incidence and prevalence of atrial fibrillation. And having said that, the approach to management I mentioned last time is rate control, rhythm control, anticoagulation, and then the ablations, whether AV nodal ablation or pulmonary vein isolation and ablation of the AFib by itself. And the rate control, we use different drugs like beta blockers, metoprolol, like diltiazem. We can use digoxin and amiodarone. On the rhythm control, what that means is we convert the atrial fibrillation into sinus rhythm. That's what we call it rhythm control. The rate control is basically we block the AFib in the AV node and we slow the ventricular response. So there is one good study which was done years back called Aspirin study, which compares the morbidity and mortality benefit, whether it's rate control and rhythm control. And overall, there is no any mortality benefit. Of course, patients who has decompensated heart failure, they get benefit if you cardiovergent sinus rhythm because they get the atrial kick to fill in the ventricle. But overall, you can do rate control, rhythm control, and the main other management approach to atrial fibrillation is anticoagulation. So to do anticoagulation, we have to use the CHADS score. So this is a matrix that can help us to risk stratify patients who are at increased risk of stroke. So the CHADS score is a simple put in these conditions and it gives you the metrics. So the CHADS score involves congestive heart failure, age, diabetes, history of stroke, female gender. So once you put in those numbers, if the CHADS score is 2 and above, you can anticoagulate these patients either with Coumadin or the novel NOACs. If the CHADS score is less than 2, you can get away with aspirin. The idea is once your CHADS score is 6 or above 6, the risk of stroke on those patients is about 18%. So that's the summary I have. Probably I'm going to come back on the question answer session. But I will share with you all the slides of the AFib, A-flutter so that you can review it. And thank you.
Thank you. Just to be sensitive about your time, Henok, do you mind if Dr. Mikias also talks about 5 minutes and then we'll let you go by 7:30? Is that okay?
Actually, I'm going to join you when I go on the road.
Okay, yeah. Perfect. So why don't we shift gears, and also then I'd like to ask Dr. Mikias to maybe go over the highlights of your presentations, and see if you can use maybe 7 minutes, 7.5 minutes to talk about, some of the topics you covered, Dr. Mikias.
Okay. Can I take a few minutes to bring up a case that I saw a few days ago and see what opinion people have as to what I should do?
Sure, we can do that.
So I had the pleasure of taking care of a 66-year-old female. She's actually from Eritrea. She had come to the US almost a year ago or so, and was admitted to our hospital initially with cardiogenic shock. And she was found to have severe mitral stenosis, and also atrial fibrillation. From what I gather, I think she had the atrial fibrillation for a long period of time because she told me that while she was in Asmara, she was having palpitations and had been seen by a doctor, done an EKG and stuff like that. So we had replaced her mitral valve while she was here and did very, very well after mitral valve replacement. She was very cachectic, had gained weight, her respiratory issues had resolved, but still had persistent atrial fibrillation. So she's 66 and a female. She doesn't have hypertension. She doesn't have any other comorbidities. Her LV function is normal. Now she comes to my office and she says, I want to go back to Asmara. And I had placed her on warfarin. She says, oh, I will not have a way of checking this while I go to Asmara. What do I do? So what do I do here? Do people have an opinion? I really don't know. She hates the medicine. She says, she doesn't like going to the hospital to get it checked. And on top of that, she really, really wants to go back to Asmara, which she does not have a way of checking her INR. So what do I tell her? How do I counsel her? Do people have an opinion about this? And I really don't know what to say to her. That's why I'm asking.
So is your question, can people do INR in Ethiopia and in Asmara? That's one question. Is that what it is? And is the medication available? Is another question.
What do I tell her? So now, she really has a risk of having a stroke, right? Yeah. How do I counsel her? She says she has to go to Asmara. She really wants to go because she likes breathing the air when she gets there. And she doesn't see herself staying in the US. And and I am stuck with the option of, or with the task of letting her know what she's putting herself at risk. So she has a risk of stroke. So what do you tell this patient? I can't, well, somebody can say, oh, go ahead, do whatever you want to do. But my job as a physician is to let her know about the risk and benefits of doing something versus another. And the other question is, can I use a NOAC, for example? Like Xarelto or rivaroxaban, is there a contraindication, indication? People have an opinion about this. How do we see gender as independent predictor for morbidity due to AFib? Okay, gender in itself does not count. So if it's just a female gender, we don't use it. But if it is gender plus hypertension, that gives you a CHA2DS2-VASc score of 2. And in her case, she is 66, that gives her 1 point, and a female, that gives her another point. So her CHA2DS2-VASc score is 2. It's not 5, but it's 2. So the risk of stroke is about 2 to 3% per year.
And does she know what stroke is? Does she understand what stroke?
That's a good question. I haven't asked her, what she knows about stroke. So that is one thing that I can do to make sure that she understands what the implications are. So, okay, I won't take up my time, but let me tell you some of the research that I did about this. So I called some of my EP colleagues. So there is a label on Xarelto and rivaroxaban that they should not be used with valvular disease or for valvular atrial fibrillation. So that's a very wide term, but we apply it only to people who have had rheumatoid mitral valve disease or mitral stenosis. That is what that means. And the question is, since she has her valve replaced, does it change really the underlying physiology of rheumatic inflammation? Because, it involves probably the atrial tissues as well. So you are replacing the valve. So there is some degree of inflammation that remains. I mean, ideally, this is not a medication that we should be using. But Xarelto or rivaroxaban is certainly an option for her, though it's a fairly expensive medicine and something that she may not have access to. It is very tough. I think at some point she will go. The other option that I was thinking was to just give her a low dose of the warfarin and hope that she will continue to do okay, but still a risky option. Truly, there is really no good way out of this. But ultimately, my job as a physician is to make sure that she understands the risk and benefits of doing a certain action. Her job is to decide. I placed a 2-week rhythm monitor on her a few days ago, and she will come back in about 4 weeks to discuss whether she will just go out without any medications, whether she will go on Xarelto or rivaroxaban or warfarin. Anyway, I had 2 sessions. The first session that I had was on EKGs. So NOAC possible if not pregnant or lactating, not with moderate to severe AS, not with mechanical valve. Her GFR is not. Yes, that is 100% correct. She doesn't have any other valvular disease except for her mitral valve, which has been replaced. You are right. She has a bioprosthetic valve, not a mechanical valve. But in the other concern that I have about the NOAC is access. Some people get their medicines sent over to them from here since they have some sort of public insurance, but the public insurance runs out in about 6 months to a year. So whether she can get those medications in Asmara or not, I don't know. I heard a few weeks ago that there is some availability of rivaroxaban and Addis, which I was very happy to hear about. Okay, so the first session that we had was on EKGs. So it's a very, very important basic tool that all physicians, not just cardiologists, need to master. It takes time. It takes a lot of effort. It takes your willingness to be vulnerable, to make a mistake in public, to really improve your skill sets. And I encourage you that every time you do an EKG in your institution, bring it to the morning report, place it on top of a big board, and have somebody out there and who doesn't know about the EKG try to give you an attempt on the interpretation and learn as a whole. Some of the basic things that you need to know about EKGs include EKG changes with acute coronary syndromes, EKG changes with basic electrolyte changes, EKG changes with basic arrhythmias, such as atrial fibrillation and atrial flutter. I showed you things like hypertrophic cardiomyopathy, but in all honesty, those diseases are incredibly much more rare than the common things such as atrial fibrillation. I hope you had fun with it. The second lecture that we talked about, I wanted to show you some of the basic tools that we have in cardiovascular evaluation, that being echocardiography. If you have any basic ultrasound machine that has a cardiac capacity, try to play around with it, especially in the ICU, for checking IVC size, at least grossly determining whether a person has pericardial effusion or not, whether they have gross valvular disease. Trust me, if it is very severe mitral stenosis or aortic stenosis, the very basic views will tell you that, and whether they have LV or RV dysfunction. We talked a little bit about the management of tamponade. Remember, the first line of treatment for tamponade while you're trying to get it drained is fluids. Don't give diuretics. You're going to harm the patient. And ultimately, if this is going to kill the patient, you might as well try to stick a needle in there and take it out, even if you don't have the capacity to, you don't have a full-fledged cardiac catheterization lab or set up to do pericardiocentesis. I think that's about it. Okay, any role screening for AFib. Most of our AFib patients, their first presentation is embolic event. Okay, so that's a very complicated question. So, can you hear me?
No, yeah, go ahead. Yeah, I think it's someone who unmiked, unmuted their mic. So.
Okay. So, so when you have a patient that presents with stroke, and their EKG shows normal sinus rhythm, or non-AFib type of non-AFib atrial flutter rhythm, you are right. The question is always whether you screen these individuals for AFib or not. And that is a very complicated question. And the reason for that is, so if you have AFib on the EKG, those two are associated, you're good. But when you don't see it, the question is there some other explanation that is high on the list that could explain their stroke, or is it that you don't have any explanation that you need to search for AFib? So if you have a a 69-year-old man with very poorly controlled diabetes and very high blood pressure, and you do a carotid ultrasound and you look at a whole lot of plaque in there, and that person has presented with stroke, to me, it doesn't make sense that you would search for AFib in that patient. But in a person that doesn't have any other explanation for their stroke, then you need to look for AFib. The question is, how deep do you look for AFib? So there are 24-hour monitors, there are 2-week monitors, and let's say that they don't show any atrial fibrillation. It doesn't mean that it doesn't exist, because the AFib can happen right before you put in the monitor and right after you put the monitor, and you still can miss it. In this country, we have this implantable loop recorders that is going to allow you to record a person's rhythm in real time and continuously for about 6 months, a year, that kind of period. But in your case, I think what makes sense is that if you have no other explanation for AFib and you suspect AFib, I would empirically just anticoagulate them.
So I think, as Miki has said, it's not only the heart, but it can also be the aorta. It can be any of the other vessels as well. So it depends on where the embolic event is. Is it a mesenteric catastrophe? Is it an embolic event to the lower extremities, to the brain? It's not always stroke. So I think, in those patients where there is no, clear indication of atrial fibrillation, we also do scan them with a CT angio to look for any aortic source. Sometimes there's an aortic ulcerated plaque or, occlusive disease, and so on and so forth. So, and if we don't find any, and that's when, at least here in our case, we exclude other sources and then send them back for monitoring. Enoch, can you hear us? Is there anything you want to add?
Yeah, can you hear me?
Yes, we can.
Yeah, so, in the management of stroke these days, we are liberal on using transesophageal echo on patients with stroke, and it would help you to rule out any left atrial appendage thrombus if the patients have any paroxysmal AFib or AFib, or if there is any intracardiac atrial shunt. And also you can scan the aorta for plaque, but what Dr. Mikias is talking about is, when we have patients, we call it sometimes cryptogenic stroke, where we don't know the cause of the stroke, especially in young people. Sometimes we may end up putting, monitors to identify for paroxysmal AFib. And you would be surprised that how many people has paroxysmal AFib, especially now with the new advancement of technology. People, they use Apple Watch and so on, so that, they can monitor their heart rhythm actually. Sometimes I see patients who bring me from the Apple Watch, some device they, wear, where, they detect AFib and some sort of supraventricular tachycardia. So basically high index of suspicion, to rule out, paroxysmal AFib, because when you do EKG, you may not find it at the first time, and sometimes, it takes some time to identify these arrhythmias, because it could be paroxysmal. So that's what I have as far as the stroke go. but we use liberal TEEs on patients with stroke to rule out any left atrial appendage thrombus, any plaque in the aorta, and also intracardiac shunt. Thank you.
So Mikas, is the lady from Eritrea that you mentioned earlier, she has no clots anywhere? Is that correct? At least in the atrial appendages. And then there is also a question here that said if the cause of the atrial fibrillation is taken care of, like, it took care of hepatotoxicosis or alcoholism or whatnot, and the patients are no more in atrial fibrillation, do we need to still, treat them as if they have an atrial fib? So in other words, the causative agent is gone. Are they cured if they have no EKG findings?
Technically, so for the first question, does she have a plaque somewhere else? Well, we haven't scanned her, but in this case, she didn't have a stroke yet. So I don't think there is a need to scan this lady. It is for prevention of thromboembolism that I'm giving her. So I'm trying to prevent a stroke. So it is about predicting risk and helping her understand what the risk and the benefit of the anticoagulation is. There's a couple questions. So the first question is, you're right, if the underlying disease is treated, such as thyrotoxicosis, another common causative agents, or another common trigger is sepsis, for example, sepsis-related AFib. Once you treat those underlying conditions and you have some sort of a documentation that the AFib has gone, technically you should not be treating these patients with anticoagulation. What is the approach for AFib in the presence of vegetation and acute infective endocarditis? Are you asking if we should anticoagulate them? Because I would be very, very cautious about doing that, because a lot of these patients have septic emboli, microaneurysms, especially in the brain. So I would be very hesitant about giving anticoagulation to a patient that has endocarditis. And on top of that, they also have coagulopathy, thrombocytopenia, and things like that. So it's a case-by-case basis, but mycotic aneurysms, I would feel very hesitant about giving anticoagulation to those patients. So in the absence of thrombi after TE, can we rule out embolic stroke? No, you can't. You cannot. So it could be that, the reason why they had the stroke to begin with is because the thrombi has left the left atrial appendage and is now empty. So an absence of thrombi does not rule out embolic stroke.
Any other questions?
Yeah, so to add to what Dr. Mikias was saying, the other question was about AFib associated with alcohol. And sure enough, we see a lot of AFibs, especially in young kids, college students. Actually, we call it the weekend AFib. They have good time on Friday, Saturday, and they show up on Sunday, on Monday, and they are with atrial fibrillation. Those patients, they don't have any structural heart disease, and usually it resolves spontaneously, and you don't have to anticoagulate them. Thank you.
Good. So I think it looks like there are no other additional comments or questions here, unless Dr. Mikias, you have anything you want to add?
Well, I'm just curious. How do you monitor for AFib? Do you guys have this outpatient event monitors? And if so, for how long can you monitor a patient? 24 hours, 48 hours, 2 weeks? And just curious, how much does it cost, if you guys know?
So you're asking the Holter monitor kind of devices?
Yes.
Anyone from the cardiology services that can answer this question from Addis or anywhere else? Any monitoring devices you send patients with at home? Yeah, many years ago, it used to be
48-hour Holter. Okay.
and we usually keep them in the hospital, right? They don't go home with it, or am I wrong? Do they go home with it?
And Nijalim, is this a cardiology service or an inpatient? I mean, a hospital. And curious, how much does it cost to do that for a patient?
You mean if it's a private practice?
Yes, or cardiac clinic at St. Paul. And okay. And what is the cost to the patient?
The public hospitals are usually not that expensive, right? So we probably don't know what
Okay.
it is in the private hospital setting.
Okay, I think that suffices for me.
Good. So
it says NOAC for moderate to severe MS. It's not clear why they are contraindicated for just being out of NOAC trials. Yes, that there is a reason why they place them outside of the trial, because the pathophysiology. First of all, if you have rheumatic mitral valve stenosis, so it's a progressive inflammatory illness. So to me, those patients are high risk. Unless you show that it helps in those patients, it's hard to extrapolate the data where those patients were not included and put them in that category. I'll show you a couple of echocardiograms in the future, but you see smoke and stagnant blood in the left atrium whenever we do mitral stenosis, transthoracic or transesophageal echocardiograms. I think rather than a contraindication, I think you should use it as a lack of indication for using those drugs in those scenarios. In this case, CHADS2 less than 2 is the benefit of aspirin convincing compared to no aspirin. So my understanding, and I'm sure there's a lot of papers out there, and you might bring a paper that is contrary to what I'm telling you, is the benefit of aspirin is minimal to none, that I don't give it to anyone with atrial fibrillation right now. So the options you have is, if you have 2, you need anticoagulation. If you have a CHADS-VAS score of 1, and that is not just a female gender. If it is a female gender, you don't count it. So that let's say you have a person with just hypertension as their 1 risk, then you need to talk to the patient about the risk and benefit of anticoagulation. It's very gray zone. So we use what the person wants to do as a gauge to make a decision. But if they say no anticoagulation, I don't give them aspirin. The bleeding risk of aspirin is actually higher than what we have always thought. So now we don't use it prophylactically for coronary artery disease in everyone that comes to our office, or so aspirin is a no-no for me. And 0, obviously, you don't need anything. So as far as I'm concerned, no aspirin in relation to AFib. It has 0 almost.
Henoka, if you're able to speak about aspirin and in low CHAD scores, what would you say?
Well, so the idea of anticoagulation in atrial fibrillation is, to see the benefit analysis on preventing stroke and avoiding the complication of bleeding. So I am a strong believer of aspirin if the CHAD score is less than, 2. Even though the evidence is not as strong, it's not strong anticoagulant as the other agents like Coumadin. If their CHAD score at least is less than 2, especially if it's 1, there is indication for aspirin. But if there is no any CHAD score like 0 or something, and you don't have to do aspirin at all. Those are the patients that I spoke earlier, the young guys, they don't have structural heart disease, it has one episode of AFib and, it resolves spontaneously. So if the CHAD score is, they don't have any score like 0, you don't have to use aspirin. If it's 1 and 2, even patients, more than 2 CHAD score, if they have increased risk of bleeding, we don't put them on anticoagulation with Coumadin except aspirin. Thank you.
So I think to stay on the aspirin issue, I'm not sure if this has changed your practice, but I think the latest information are consistent with the fact that use of aspirin in elderly greater than 70 years of age who have no history of cardiac issues or stroke may be actually at a more higher risk of bleeding. I think that's now becoming more prevalent in the clinical practice. Am I correct, Milkias, from your perspective?
Yes. So if you look at the previous recommendations based on from the U.S. Preventative Task Force and a lot of the cardiovascular medicine guidelines, they had a very liberal criteria for initiating aspirin for primary prevention for both stroke or presence of plaque or acute MI. Now, how do you guys know about the ACC cardiovascular risk calculator? So basically, these days, I use either an exceptional clinical indication, such as presence of plaque on a cardiac CT, or your risk on the ACC-AHA 10-year risk pool must be greater than 10% for me to initiate aspirin. So I routinely calculate the ACC-AHA risk calculator to predict a person's risk of acute MI before making a decision. I can send you guys the link. If you just type ACC-AHA risk calculator, there is the latest risk calculator that comes up, and you plug in the information, and over 10%, you need aspirin.
Yeah.
Okay, so to add some points on the anticoagulation, especially most of the patients we have here with atrial fibrillation, they have also coronary artery disease and sometimes with stents. So always the question comes, these patients with coronary artery disease with stent, AFib, they need to be on anticoagulation with Coumadin or the NOACs, and they need to be on antiplatelets. So, the guideline is we use triple, like aspirin, Plavix plus Coumadin or NOACs. So, but the problem is when you add Plavix to Coumadin and you have aspirin, there is increased risk of bleeding. So what we usually do is we drop the aspirin. You drop the aspirin and you put these patients on Plavix and Coumadin or Plavix plus or NOACs. And if we have to use aspirin,
then we use it only for the first 1 month to 3 months. But usually we drop it after that to reduce the risk of bleeding. Thank you.
I think somebody asked, is there any place for pharmacotherapy for recurrent AFib other than catheter ablation? Yes, absolutely. So I think, if I may ask, Asibo, Dr. Asibo, are you a cardiologist or an internist? Just out of curiosity. Okay, while you answer that, I'll give you my answer. So the first decision branch point, in my opinion, is whether you are choosing rhythm control or rate control. There are a specific set of patients that will definitely, Blackline Hospital, Cardiology Clinic, okay. So there are a subset of patients that will benefit from rhythm control. So I'll give you an example, first of all. Several months ago, I had a patient who came in with his first episode of atrial fibrillation. He had a cardiomyopathy. His EF was 30 to 35%, and he had moderate mitral regurgitation, moderate to severe mitral regurgitation. We did a coronary CT angiogram, and he did not have a coronary, he didn't have any plaque. So basically, he has AFib, a cardiomyopathy, and some degree of mitral regurgitation. We thought that his cardiomyopathy was due to his AFib, okay? So what we did was we cardioverted him, which is the first line of rhythm control. It's not catheter ablation. You have to change the rhythm either pharmacologically or through cardioversion. We cardioverted him, and we placed him on amiodarone, okay? And he has stayed in sinus rhythm ever since. His EF normalized, his mitral regurgitation went away, okay? So I don't do that for everyone. For example, if I have a 65-year-old man with normal LV function and comes in with first episode of AFib, I don't necessarily cardiovert everybody or put them on rhythm control. But in his case, he had a cardiomyopathy due to AFib, valvular disease due to AFib. We tackled the AFib. Everything went away. There is maintenance medication such as amiodarone, sotalol, ticosine that you probably don't have it available in your, with you, I'm not sure. So there is that option for maintenance, and there's also pill in a pocket approach for patients who have episodic, very symptomatic paroxysmal atrial fibrillation. You can use flecainide. I think you can use propafenone. I think yes, there is definitely a role for pharmacotherapy in patients with AFib for rhythm control.
Well, great. In the absence of, so here is one last question maybe for you and Nikias, as well as to kind of, what is the role of double antiarrhythmic medications, I guess, in this particular case, particularly, I think, a recurrent AFib case? I think that's the question.
Okay, so I want to caution you about one thing. So antiarrhythmics are good medicines, but they have several side effects, right? So the most common one that one of the more common ones is amiodarone. Amiodarone has a lot of toxicity. Sotalol can give you prolongation of the QT interval, can subsequently inducing ventricular tachyarrhythmias, and a lot of the antiarrhythmics show actually an increased mortality data. So you have to use them with caution. So, and I don't think I have ever had any patient that I can remember off the top of my head with double antiarrhythmics. I think that is almost a no-no in my opinion.
Henok, any thoughts?
Yeah, so in general, all the antiarrhythmic drugs are pro-arrhythmic. And some of the studies have shown actually increase mortality and morbidity. So usually in terms of AFib, we usually stay in controlling the rate with, with the beta blockers, calcium channel blockers, and also try to cardio them. But there are some subsets of patients that, of course, we use antiarrhythmics, and we can use sotalol. The problem is these patients, when you start them on sotalol, they have to be admitted to the hospital to monitor their QT interval for at least 48 hours. So if you can stay away from the antiarrhythmic drug, but if we have to use sotalol and amiodarone, sometimes we use also propofenone and flecainide. But remember, some of the drugs, they are contraindicated in patients who has coronary artery disease or structural heart disease. Thank you. And I may add, if you have to use of all the medicines, I think amiodarone is the way to go. Amiodarone can treat AFib. You can use it for ventricular arrhythmias. But understand the side effects of this drug. It can affect the thyroid, sometimes the liver. Sometimes we see pulmonary fibrosis, acute pneumonitis. So just we got to be careful. But of all the most of the drugs, we prefer to use amiodarone. Thank you.
Okay, well, this was really a very a nice panel discussion and summary question and answer series. And Malako, we can stop recording. Just want to say,